There is no way this is happening. Not now, not ever.
Mom, stop!
No, this is what you had in mind for your fun weekend with your aunt?
All right, I was trying to help her.
No, what would have been helpful is telling me that my daughter is pregnant. Instead, I find out from a confused teenage boy.
Jackson told you?
Yeah, he did.
Whoa, everything okay in here?
This is Mrs. Wheeler, Christy's mother. Lynette is Christy's aunt.
She doesn't want to have this baby.
This has nothing to do with you.
Okay,
No,
maybe
I
we just
called
take
Aunt Lynn. Okay, I don't want to be a teen mom.
For context, the girl here is 17 and trying to get a medical abortion as a minor. The problem is that in Pennsylvania, the law states that an unemancipated minor must obtain informed consent from at least one parent or legal guardian before an abortion can be performed. So, her mother, being her parent, is denying the abortion and hence the dispute here. The girl was trying to take a tablet of mifepristone for it and was stopped.
Well, then maybe you should have thought of that before you started having sex.
Okay, emotions are running high. I think a private conversation between mother and daughter is in order. Lynette, let's you and I step out. I'll buy you a cup of coffee.
Some states demand a parental notification, meaning that the minor must inform a parent but doesn't need their approval. Some states have no requirement, meaning minor can get an abortion without parental involvement. Some require parental consent, meaning permission from a parent, like in this case here. Then there is the option for judicial bypass, meaning the minor can ask a judge for permission without involving parents.
Crashed ambulance, thieves are en route. ETA 10 minutes, trauma 2 is all yours.
Great.
So, a mass casualty is incoming and the ER is going to be very busy.
They better be meth head junkies, because Abby wants a Birkin for her birthday.
What are you gonna do with the Birkin?
Hopefully forgive me for getting the kids a golden doodle.
You wanna be a good husband? Send her on a vacation. Without you, or the kids, or a damn puppy.
Are you mean to everyone or just me?
Just you.
Hey, what's the status of the head CT on Joseph Marino?
Still waiting on results. He's postictal and sleeping in North 2. No more seizure activity.
Good.
Postictal means the third phase of a seizure. The seizure is a generalized tonic-clonic seizure, with the initial phase, the tonic phase, where there is generalized stiffening of limbs with arms flexed and legs extended, with the eyes deviated upward or laterally. Apnea or lack of breaths and cyanosis may occur briefly as well. There could also be clenching of jaws with risk of tongue biting. There could also be frothing at the mouth or involuntary urination. Then there is the clonic phase, where there is involuntary rhythmic jerking of limbs, as we saw on the previous episode. This then transitions into a postictal phase with flaccid unresponsiveness, confusion, drowsiness, headache, and postictal amnesia, meaning no memory of the seizure.
Let me know as soon as those CT results get back.
Yeah, of course.
How's Travis, our tonsillectomy patient?
Oh, I just dropped him off at surgery. He's doing well.
Good work.
He's referring to the tonsillectomy patient who had his airway secured through retrograde intubation and manual pressure with gauze over the tonsils. As said before, the surgery now involves identifying the bleeder and ligating or cauterizing it to stop bleeding once and for all at the tonsillar bed.
You kept him from bleeding out.
Oh, no, come on, that was all you and Dr. Robbie. I mean, I could never have done what you guys did with that airway.
Not yet. That's why you're here. But you stayed with him the whole time. He would have died at most other hospitals.
Medicine is always a teamwork. You don't have to do the most complicated surgery to save a patient's life. Just observation and monitoring and identifying an emergency could make the difference.
Yeah. No, I guess you're right.
Yeah, I usually am.
I'm sorry about all of this. I didn't think that Eloise would find out.
Yeah, well, she did.
Christy should make her own decisions.
Unfortunately, in Pennsylvania, that is not allowed, and a mandatory parental consent is required. The medical team did try their best, although the ultrasound findings were hovering very close over the 11-week mandate.
Unfortunately, she's still considered a minor. Why don't you take a seat? We'll come find you if there's an update.
What do you need, Robbie?
Escaping?
Dr. Rabinovich.
Gloria.
We're already so overwhelmed with taking care of multiple patients at once, and the administrative stuff does add unnecessary burden to doctors and also interrupt the flow of care as well.
This is Dr. Tracy Morris, Regional Manager of ECQ America.
The contract management group.
It's a pleasure to meet you.
Likewise, but if you'll excuse me, I'm a little slammed as per usual.
We were upstairs with the executive team going over a proposal.
A proposal?
We're interested in having your emergency department join us.
The 500 or so ERs you have aren't enough?
What can I say? Business is good.
Yeah? For who?
Everyone benefits.
Do they, though? Your contract management's corporate mandate is profits for shareholders above everything else, yes?
I like how this series talks about everything that's wrong with healthcare practice as well. It is true that corporations owning healthcare practices do prioritize profits over anything and everything else. Yes, you could say, well, it's a business and whatnot, but healthcare is not a product to be sold. It's a basic human right and is deeply tied to humanity and real human lives, not inanimate objects. Unpleasant and infuriating experiences start to arise when you see these companies doing anything for just even a little profit. They would happily deny essential healthcare to a dying patient if that makes them extra bucks by stepping over humanity and altruism. Just look at this lady and her interactions with Dr. Robbie till now. She seems to be more worried about superficial stuffs like some arbitrary satisfaction score and blaming doctors for it, while not even addressing the fact that most of the patients who come to ER are in the hallway due to the hospital not having enough space to accommodate patients in proper beds. Address that first instead of trying to sell the whole practice to someone else in bid for more profits.
Your hospital's board was very impressed with ECQ's metrics on patient satisfaction, throughput time, and billing collections.
Does your proposal include the part where you cut the pay for all my doctors?
It's basically cheap labor. Hospital businesses are run on as much cheap labor as possible. Pay the nurses and doctors and everyone involved as less as is possible, and make more profits with complete disregard over patient care as healthcare just a commodity for them to sell and make profit off of. The problem is the doctors and nurses who provide the healthcare do not and can never think of healthcare as a commodity. It's everything that provides meaning to life. It's the emotions tied with the patient, the highs and lows. Making money is not even a thought while taking care of patients, but it's the only thought that these corporate people hold.
Maybe I can find an incentive for you. How does regional medical director sound? Lighter workload, better benefits, stock options.
Did you go to business school or medical school?
This was my exact thought listening to her too. Just ensure patients are provided the best treatment possible. Nothing else matters.
Both. We look forward to your decision.
Of course.
Hopefully we'll get a chance to work together soon, Dr. Rabinovich.
I mean, that looks like a big no from Dr. Robbie.
I can't believe you're seriously considering this.
Bottom line is, our current numbers aren't good and theirs are.
Just because their dashboard's pretty doesn't mean it's good for patients.
If you want to keep this ED, improve metrics. There's a lot of OFI. Opportunities for improvement.
Well, you could have just said that.
I need you to care about patient satisfaction.
I would love nothing more.
Like, what is there to improve from the doctor's side? They're continuously seeing as many patients as they can. It's not that the patient satisfaction is bad because of doctors. It's because of the hospital not providing enough beds, not having more staffs because it would cost them the administration a lot of money. Why is the blame externalized to Dr. Robbie here?
But right now, the average wait time is 6 hours, and that's before you see a doctor. You need to hire more staff so we can open more inpatient beds. Are you prepared to do that?
I need you to improve scores with the resources we have, or we will explore what ECQ has to.
This is just expecting a bigger return with minimum investment and minimum wages, with little to no care about actually improving healthcare of patients.
This is bullshit. You know this is bullshit, and if you don't, then we are all in
Maybe
trouble.
you need some time off.
Hey, we got a ladder fall. A couple minutes out. Yep.
Any luck finding Ginger's daughter? She was supposed to be right back to take her mom home. I just tried her cell again, still no answer. Let me try the cafeteria one more time. What did we tell her? No, don't tell her anything yet. Oh, boy. You should consult with Kiara, just in case this goes south.
So, the lady with proximal humerus fracture has been deserted by her daughter, fearing more activities of daily living and more workload. A classic example of caregiver fatigue.
What do we have?
45-year-old Silas Dunn fell off an 8-foot ladder. Right chest hit the carpeted floor. No LOC, good vitals, no meds, no allergies.
Dr. Santos, how are you doing?
Fine. My wife called 911. These guys said this was all necessary, but I can walk.
We're gonna keep it on until we get you all checked out, okay?
What are you thinking?
What made him fall? Could have been cardiac or neuro.
Syncope is a temporary loss of consciousness due to transient global cerebral hypoperfusion, meaning reduced blood supply to the brain. This could occur due to cardiac causes like arrhythmias or even heart attack causing decreased cardiac output to the brain, or could be neurologic causes like stroke, or could even be a reflex syncope caused by vasovagal reflex due to emotional distress, pain, fear, prolonged standing, or dehydration.
Any headaches?
I was a little dizzy.
He needs a head CT, EKG, and troponin.
Exactly.
Head CT for ruling out head trauma and intracranial hemorrhage or stroke, and ECG and troponins for myocardial infarction and arrhythmias.
I was installing
Thanks,
a
guys.
lighting fixture in the
Dr. Santos on E-Fast, please.
Dr. Garcia, can you spell world?
W-O-R-L-D.
Start with D, spell backwards.
D-L-R-O-W.
Excellent.
Spelling word backwards is usually a part of mini mental state examination where we assess the level of consciousness, specifically attention and short-term memory.
Your brain is fine.
Pulse 92, BP 132/78, SAT 98.
No pericardial effusion.
As we've discussed many times before, fast scan done using a bedside ultrasound here detects free body fluids in cases of trauma like pericardial effusion or pleural effusion or peritoneal effusion in the pericardium, pleura and peritoneal spaces respectively. We could also check for pneumothorax as well, where there would be excess air in the pleural cavity. Could be relevant here since the patient fell on his right chest.
Oh, tender? Yeah. Okay, ribs 7 and 8, MCL.
You probably cracked a rib or two.
Check for lung sliding. Could be a pneumo.
In normal lungs, the visceral pleura of the lung slides against the parietal pleura in the chest wall during respiration. On B mode, 2D ultrasound, this appears as a shimmering or sliding motion at the pleural line. If the lung sliding is present, then this indicates that the pleural surfaces are in contact, which means no pneumothorax in that area. However, if there is absent lung sliding, this means that excess air is preventing these two pleurae to come in contact, which definitely hints towards a possible pneumothorax.
I was gonna paint the living room next. My wife has a whole list of things she wants us to get done.
I'm afraid the only home renovations you're going to be doing in the next couple of weeks are the kind you watch on TV.
Can you tell my wife that?
Lungs are up.
Lungs are up means the lungs are expanded and not collapsed, and in contact with the chest wall, which means the lung sliding is also present on ultrasound and there is no pneumothorax.
Miles Hernandez, 18, unrestrained driver of the stolen ambulance. Right chest, left leg injuries. Short of breath, SAT 91, tachy 120s, BP 105/70.
Tachycardia with low blood pressure, hypotension, is a red flag that typically indicates the patient is in shock, likely hypovolemic here due to bleeding within.
Can I go with him?
Is your friend?
He's my pledge.
We're going to find a room for you. Let us take care of Miles, okay?
Dr. Collins, can you talk?
Breath sounds bilateral, but lots of striders.
Stridor is a high-pitched, harsh sound heard during breathing, usually on inspiration, sometimes on both inspiration and expiration, that indicates upper airway obstruction. The upper airway narrowing or obstruction can occur anywhere from above the larynx to the trachea, causing turbulent airflow and hence the harsh sound produced. Stridor in trauma is a sign of upper airway obstruction, which can rapidly progress to complete airway loss. Early and controlled airway management is critical, which could be achieved via intubation here. Broadly speaking, in general, trauma can cause laryngeal fracture, airway edema, neck hematoma, or foreign body or blood or vomit aspiration. These conditions can worsen quickly, making intubation difficult or impossible if delayed. And from previous episodes, we do know that if intubation fails, cricothyrotomy is the emergency surgical airway of choice.
Hip dislocation, good pedal pulse.
This is relevant here because during a frontal collision, the passenger's knee is slammed against the dashboard. Here, the knee hitting the dashboard forces the femoral head backward and is a common mechanism for a posterior hip dislocation, where the femoral head is pushed backward from the joint. Sometimes, the force is so strong that on the way, it also fractures the posterior wall of the acetabulum, which is the socket of the joint where the femur head fits. Interestingly, a posterior hip dislocation can be strongly suspected just by looking at the limb's position during initial trauma assessment. If the affected leg is flexed, adducted, and internally rotated, this is the textbook position seen in posterior hip dislocation. A posterior hip dislocation with a good pedal pulse suggests that there is no major vascular compromise. Interestingly, the anterior hip dislocation is more likely to impinge on the femoral artery, vein, and nerve that run anterior to the hip joint. The structure that could be at risk if the femoral head is displaced posteriorly would actually be sciatic nerve. Pedal pulse, which is measured with dorsalis pedis or posterior tibial, being present indicates that blood flow to the leg is preserved. However, neural examination is required here to check whether sciatic nerve is intact and rule out associated pathologies like foot drop, which are relevant here.
Need induction meds, ketamine and rock.
We know that ketamine is an inducing agent and rock or rocuronium is for neuromuscular blockade to be achieved for general anesthesia, specifically rapid sequence intubation. Here, a sedative or induction agent is given to render the patient unconscious, and a paralytic is given immediately after to cause complete muscle relaxation, and then after the patient is intubated. Most emergency patients are not fasting, so have high risk of aspiration, and time is critical. So rapid sequence intubation is fast and effective.
Oh, look at this clavicle.
Depressed centrally, sternoclavicular dislocation.
If the clavicle appears depressed centrally, especially near the sternum, you should suspect a posterior sternoclavicular joint dislocation, which is a rare but potentially life-threatening injury. Here, the medial end of the clavicle moves backward, behind the manubrium, which can compress mediastinal structures including trachea, esophagus, brachiocephalic vein or artery, vagus or recurrent laryngeal nerve.
Compressing his trachea.
Reduce it, see if it helps his breathing.
Compression of the trachea seen here due to this could explain the stridor observed before that is causing the upper airway obstruction here. It would be typically associated with dyspnea or shortness of breath, hoarseness due to the involvement of the recurrent laryngeal nerve or difficulty in swallowing, which would mean the esophagus is compressed too. So a closed reduction of the joint has to be attempted in stable patients. A CT scan would be the ideal gold standard to confirm posterior dislocation and evaluate for vascular or tracheal involvement.
All right, stabilize the leg. 1, 2, 3.
Pour morphine, draw a rainbow, type in screen.
Morphine is a potent opioid given here stat for pain. Draw a rainbow simply means drawing multiple blood tubes of different colors to run a full trauma lab panel immediately. Blood is drawn and put in each of these differently colored tubes, which are meant to check different parameters in blood. Hence, some go to pathology lab, some to biochemistry, and some to microbiology. Type in screen means test for determining the patient's ABO-RH blood type and screening for antibodies that could cause transfusion reactions later, hence allowing for faster cross-match if blood is needed urgently. This is basically preparing the patient for potential blood transfusion later here.
Heart rate's 125.
The patient is tachycardic. A compensation for possible shock here with could be internal bleeds causing low BP that would be assessed with a fast scan. It's also a compensation for hypoxia due to the airway compromise here.
Letting you get on the airway, Collins, eat fast.
No blood in the oropharynx.
Bleeding in the oropharynx could have caused difficulty in visualizing the vocal cords for intubation, as was seen in the post-tonsillectomy hemorrhage patient in the previous episode.
Clavicle is dislocated posteriorly. Chlorhexidine swab, tenoblido with epi.
He's likely preparing to reduce the posterior dislocation of clavicle and preparing the area for it. Chlorhexidine to make the area sterile and lidocaine with epinephrine for providing the local anesthesia here.
Time is of the essence.
BP's 108/74.
All right, Miles, your collarbone is pushing against your windpipe. We're gonna pull it back up. I'm gonna inject an anesthetic. You're gonna feel a pinprick and a big burn.
I feel like the syringe is empty here. Pushing an empty syringe with air into the tissues is very dangerous since it could cause air embolism if it impinges on a blood vessel and the air reaches the bloodstream. It's just a series though, and every medical procedure is difficult to replicate, I guess. This is the fast ultrasound scan here. We can see this is the liver and this is the right kidney. She is likely trying to look into the Morrison's pouch, a potential space between these two structures that could be filled with blood in case of a hemoperitoneum that is bleeding into the peritoneal space in the abdomen due to trauma.
All right, towel clip. All right, go deep. You want to get a really good grip on both sides of that bone.
He's holding the right clavicle with a towel clip. The process is usually done under conscious sedation with muscle relaxation and pain control. Common agents would include ketamine with midazolam or fentanyl. The reduction technique for such dislocation usually involves abducting the arm on the affected side to 90 degrees. Gentle traction is applied to the arm while the medial clavicle is manipulated anteriorly using either direct finger pressure behind the sternum if palpable or a blunt instrument like a towel clip, like in this case, or a bone hook inserted percutaneously under sterile conditions, holding the bone and pulling it anteriorly until the medial end of the clavicle gets returned back into the joint, specifically the clavicular notch of the manubrium. Typically, a CT scan is repeated to confirm successful reduction, and the arm is immobilized in a figure-of-8 brace or sling for 4 to 6 weeks. Let's see what happens here.
Got it.
All right, Miles. It's gonna hurt for a second. You ready?
The clavicle has been pulled back here, with the medial end likely into the clavicular notch.
Excuse good.
Who are you torturing now?
Reduced a sternoclavicular dislocation.
How's your breathing?
Better.
Since the clavicle isn't compressing the trachea anymore, the dyspnea has improved.
What happened to your post-op hemorrhage?
Panicky intern. False alarm.
Who is she?
Right?
This is Dr. Garcia. We're gonna get your leg straightened out.
After we do a CT?
CT is not strictly required before reducing a posterior hip dislocation. Plain x-rays, AP pelvis, lateral hip, are usually sufficient to confirm the diagnosis, check for obvious associated fractures like posterior wall of the acetabulum or femoral head, and guide urgent close reduction. If the x-ray shows a simple dislocation without fracture, immediate close reduction is usually performed, especially in the first 6 hours, to minimize risk of avascular necrosis, AVN, of the head or femur. After reduction though, CT is typically done to confirm congruent reduction and absence of bone fragments or intra-articular loose bodies.
All set.
How bad does it look?
I'm gonna be honest with you, it doesn't look great. Thankfully, there's no signs of infection.
I'm such an idiot. And now I'm having a panic attack.
Excuse me, Dr. Moore.
I'll be right back. I've only been in with her for a few minutes.
I didn't say anything. What's the case?
Chanel Sutton, 22, complications from silicone butt injections.
With silicone butt injections, the body reacts to silicone as a foreign substance, leading to hard, painful lumps or nodules, chronic swelling, disfigurement, or distorted appearance as seen here. There could be local abscess, cellulitis, or even sepsis. The major complications from silicone butt injections include embolism, meaning silicone can enter the bloodstream and travel to the lungs and lodge into the pulmonary vasculature called pulmonary embolism or blood vessels of the brain, which would cause stroke.
So call the clinic that did it.
High risk factors for this would be if this was performed by unlicensed individuals and done in non-medical, non-sterile settings like in hotel rooms or basements, and the use of industrial silicone or non-medical fillers.
She found the guy on TikTok. He did the injections in his living room. She thinks it was maybe silicone caulk from Home Depot.
Silicone caulk is meant for construction use like sealing windows or bathtubs and contains toxic chemicals, solvents, and additives not safe for the human body. It is non-sterile, often contaminated with bacteria or fungus, and is not injectable under any medical standard. It would cause toxic reaction with severe inflammation and necrosis along with possible organ damage from systemic toxicity. Caulk is not sterile at all, and its injection can lead to cellulitis, abscesses, sepsis, and necrotizing fasciitis, also called flesh-eating infection that kills the body's soft tissue. Not only this, the caulk hardens in tissue and cannot be removed completely. So it causes lumps, deformity, scarring, and chronic pain with permanent disfigurement. It often requires multiple surgeries with no guarantee of full correction. Bottom line, silicone caulk is poison when injected and no trained medical professional would use it. This is not cosmetic enhancement, it's assault to the body, and whoever did it should be in prison.
Jesus, really? Kids today.
She's tachycardic and tachypnic.
That's a really bad sign. As we said before, this could very well be a case of pulmonary embolism from the silicone released into the bloodstream that reaches the pulmonary vasculature and obstructs the blood flow. It causes ventilation-perfusion mismatch where parts of lungs are ventilated but not perfused due to obstructed blood vessels. This causes hypoxia and hence shortness of breath and tachypnea along with tachycardia to compensate.
I think it's a panic attack, but if a piece of silicone hit a vein, she could have a pulmonary embolism. We should scan her.
Good.
For a suspected case of pulmonary embolism due to any cause, the gold standard would be a CT pulmonary angiography. It allows direct visualization of emboli silicon in this case within the pulmonary arteries using contrast-enhanced CT. Here, an iodinated contrast is injected rapidly and the CT images are timed when contrast fills the pulmonary arteries. Typically, if embolus is present, there would be filling defect caused by embolus in the pulmonary artery. It also helps to assess the size and location of the clot.
How's Joyce, our sickle cell patient, doing?
Holding up. She's intubated and waiting on an ICU bed.
Yeah, an intubated patient would ideally have to be monitored in the ICU setting. Intubation was done as her saturation dropped, increasing the vicious cycle of hypoxia and sickling with risk of complications like ischemic stroke, sickle cell nephropathy, or avascular necrosis as discussed in previous episode. Intubation has improved her oxygen saturation, stopping this vicious cycle at least for now.
Good. Keep it up.
Will do.
You're done with triage for the day.
Sorry, did I do something wrong? Because I know I said too much to the unhoused mom.
No, don't worry about it. It's cool.
The patient with the sternoburn did feel a sense of her confidentiality breach and lashed out. It's a lesson to be learned that trying to help won't be received positively if you don't gain patients' trust beforehand, even if the intent was good. It's only after sufficient rapport that enables us to discuss and guide for necessary interventions, especially if deeply personal issues are involved. Otherwise, you'd end up losing patients in their follow-ups.
I just want to remind you all of a few things, okay? So we do a great job coming up with the right diagnosis and treatment plan for our patients, but there are still some opportunities for improvement.
Not this bullshit again.
Always sit down at the bedside of a stable patient. It will make you a better doctor.
This simple act of sitting down shows presence and respect. Sitting signals that you're not rushed. The patients feel seen, heard, and valued. It encourages open dialogue and compassionate care, which improves patient satisfaction and outcomes.
Second, if there's a discharge to be done, do it before you pick up a new patient. The patients are very aware of the time that they spend with us, so please don't keep them here any longer than they need to be.
From where I work, the discharge from the doctor's side is completed pretty quickly. It's the billing and all other administrative stuffs that come with it that actually delays the discharge and makes patients frustrated with having to wait.
Maybe they complain about the wait.
I get it, but for the sake of efficiency and running smoothly on our end and opening up beds and opening up rooms, let's discharge before we start with somebody new, okay?
I guess that's the only thing doctors can do about the insufficient beds. Not only in the ER, it's the same with the ICU as well. Shift the stable patient to the ward, and only an ICU bed is available for a patient in the emergency. The root problem is always the lack of beds, which is rarely addressed.
Thank you. Lastly, in your medical records, make sure that your decision-making and your notes reflect not just the diagnosis, but all the thought that you put into ruling out all the critical illnesses in the differential.
More work? I do enough charting as it is.
Yeah, more paperwork. The paperwork is what makes the medical practice mundane at times. Doctors want to treat patients and not get stuck with too much non-medical stuffs. It's never fun to write several pages of notes for admitting a patient to ward at 2 a.m. in the morning, while you should essentially just be treating patients and writing orders and sleeping. It just increases the panic of leaving untreated patients behind due to it, and honestly makes the work more worrisome and tedious when it shouldn't be.
The hospital won't admit this, but it's less about charting and more about profit.
More details means more detailed diagnosis, comorbidities, and complications, which could mean higher paying diagnosis-related groups or DRGs, and hospitals are paid for the cases using these DRGs. Writing just sepsis versus sepsis with acute kidney injury and diabetes with complications will have drastically different DRGs and reimbursement.
I need to check on my Nepali patient. She likes me.
Everybody likes you when they're on morphine.
So, this is the Nepali patient who had a degloved leg with fracture, which was manually reduced in the ER with a popliteal block. She is on morphine acting as an analgesic here.
These are student doctors. Mind if I do a little teaching?
Go for it.
Now, everyone knows McBurney's point.
McBurney's point is a clinically significant anatomical location used in diagnosing acute appendicitis. It lies 1/3 of the distance from the anterior superior iliac spine to the umbilicus. Tenderness at McBurney's point is a classic finding in acute appendicitis. Interestingly, it indicates localized peritonitis due to inflammation of the parietal peritoneum overlying the appendix.
But who can tell me the name of this sign? Tim, raise your right leg, please.
So, this is the classic psoas sign seen in a case of acute appendicitis. Here, asking the patient to actively lift the right leg against resistance by your hand causes pain, as the inflamed appendix irritates the psoas muscle. More specifically, it suggests retrocecal appendicitis, retrocecal meaning the appendix being located behind the cecum. In this case, the appendix lies close to or over the right psoas muscle, and its contraction leads to even more rub and pull of the inflamed appendix, increasing pain from appendicitis even more. This could also be elicited by passively extending the right hip with the patient lying on his side, as it also stretches the psoas muscle, causing similar pain.
Oh! Psoas sign, causing friction of the psoas muscle over the inflamed appendix.
Excellent. Now, back in the day, appendicitis meant you went straight to the OR. Who can tell me about the CODA study?
The CODA trial, that is comparison of outcomes of antibiotic drugs and appendectomy trial, is the largest randomized clinical trial to date comparing antibiotics with appendectomy for the treatment of acute appendicitis. Conducted across 25 U.S. medical centers, it enrolled 1,552 adults with imaging confirmed appendicitis and randomized them to receive either a 10-day course of antibiotics or undergo appendectomy. At 30 days, antibiotic treatment was non-inferior to appendectomy. By 90 days, 29% of patients initially treated with antibiotics required an appendectomy. This rate increased over time, with 49% undergoing surgery by 3 to 4 years. Notably, patients with an appendicolith, which is a calcified deposit in the appendix, had a higher rate of subsequent appendectomy. The conclusions were that while antibiotics are a viable first-line treatment for many with uncomplicated appendicitis, individual patient factors and preferences should guide treatment decisions. Following the CODA trial, several professional professional organizations, including the American College of Surgeons, have updated their guidelines to recognize antibiotics as an acceptable first-line treatment for uncomplicated appendicitis. Patients with an appendicolith may have a higher risk of treatment failure with antibiotics alone and might benefit more from immediate appendectomy.
Well, it's from a 2020 New England Journal trial comparing surgery to antibiotics. It showed that without an appendicolith, there was a 75% success rate in the antibiotic-only group.
Exactly. Honey, we discussed the study at home, right?
Honey? Wait, she's your mom?
It's Victoria. Or Javadi. Dr. Shamsi?
I don't know about this scene, but it must be awesome to have your parent as a doctor and a professor in medical school to guide you all the way. Maybe awkward at times like this scene, but I guess having your parent as a doctor is a huge plus in med school.
Hello? Oh, yeah, I'll be right there. Mrs. Grant now has chest pain, if you'll excuse us.
Oh, yeah, go. Patients come first.
Okay.
Who's Mrs. Grant?
Nobody, I made her up. Sorry. You just had that look on your face my son gives me when I give his basketball team pointers from the sideline. I'm sorry.
Sneakily got her out of the awkward situation there. Thanks for watching. Part 2 is yet to come. Please subscribe to support the channel.